A very big warm welcome to our AHP Careers webinar. And today we will be focusing on 4 other professions. So we've got dietitians, prosthetists, orthotists and operating department practitioners. So it's really likely to be, it's going to be a really good overview of some of our smaller professions who you may not have heard of. So if I can introduce myself, my name is Janet Folland. I'm the AHP faculty lead for North East North Cumbria, which the AHP faculty is a sort of structure within the system of North East North Cumbria, where we work with AHPs across the system to look at workforce sort of issues. I am an AHP by background. I'm an occupational therapist, and currently, as I say, we're working across the system, and very proud allied health professions. So what you'll hear about is that collectively, a whole group of professions, we are a collective allied health professions. Next slide, please. So in today's webinar, we will be joined by a range of colleagues from all those professions we just talked about, the 4 professions, to explain about AHPs, as we tend to shorten ourselves to, so Allied Health Professions or AHPs, where we work, what we do, and in particular, we'd like to provide you with information on how you can become one of our very valued professions. And before we introduce the other people from the 4 professions, we will also be looking a little bit about how the system works. And there'll be a chance at the end for any questions. And also, if you have any questions as we go through, please do put them in the chat and we'll pick up on them when we get to the end. Next slide, please. So just now I introduce myself as working across the North East North Cumbria system, and the map you see here is the North East North Cumbria system. So you will be so probably living somewhere within this map, and in your area you will have access to a whole range of different health and care services. And as you'll see in the little boxes on the sides, our health and care system is made up of all of these. You'd probably have heard of the NHS organisations. You'll probably be aware of maybe your own NHS trust in your own area. But we also have allied health professions working within primary care or GP practices, also within social services and voluntary organisations, in schools and education, prisons, care and nursing homes, community organisations, and a whole raft of other organisations as well. So as a group of professions, we really do cover all the bases in terms of our health and care system. We work across the age span, so we work with the whole age span. So from neonatal babies through and children, all the way through to older people's services and everything in between. We focus on a whole range of different services like acute services, rehabilitation, mental health, and the various children's services. So, we are quite a varied group, and we cover a whole varied group of organisations. So, next slide, please. So, who are the allied health professions? So we are a group of health professions who are distinct from nursing and medicine or doctors. We work within 15 different professional groups, and together we provide a whole range of sort of diagnostic, technical, therapeutic and support services. And if you can see the names underneath each of those little icons, you will see all the different professions that we cover. And the range and scope of our professions is hugely diverse, and so it's really exciting actually. So from art therapy or drama therapy through to orthotists, osteopaths, paramedics, speech language therapists, the whole spectrum. We cover a lot of services. We are the third biggest workforce in the NHS collectively. So after doctors and nurses, who are the largest professions within the NHS, but after doctors and nurses, collectively we are the third largest workforce. We are professionally registered, and we work as autonomous practitioners within our chosen professions. And each of our professions has a dedicated support workforce, and that quite often can be a route where people sort of get to know and enter our professions, as well as direct entry. Next slide, please. And I'll hand over to Marie.
Hi everyone, I'm Marie Constable. I'm a practice placement facilitator. So you might see me if you were on a professional course and coming into a hospital trust to do a placement. So my role is around making sure that people who are on AHP courses get the right experience as part of that course. So Janet mentioned there, we have support workers who work across the AHP professions. So you might come in at a band 2 level. So to become a band 2 support worker, you have to have your maths and English, and it's desirable if you had some experience in the past, but it's not completely necessary because you would get your training in-house. So you might then progress up to become a band 3. So at that level, you know, it's desirable if you have A levels. It might be you're at the point in your career now that you're doing your A levels and you're thinking, what could I do? You might want to apply to a trust to be a band 3 support worker. So you can do that at a voluntary or a paid route. And then the step up from that is a band 4. These are often called associate practitioners. So you can do a course at college or at university to be as an associate practitioner. You can do that alongside working as a band 4, but you would have to apply for that. So they're the sort of support worker levels 2, 3, and 4. But if you want to join the HCPC register as one of the professions, there are 2 routes generally. So we've got the apprenticeship route, or we've got the university route. So with apprenticeships, you need to be working in a place that offers an apprenticeship. So that's a paid route, but you need to be in employment first. So it might be that you've gone through the support worker route, and then you then go on to become an apprentice in a profession. You know, for example, occupational therapy, ODP, you know, we have lots of apprenticeships now. The other route is to apply to a university to become an AHP. So you would do, so one of those 15 professions, you can do courses in those. So you would do your course at your university, but then you would come to places like my trust and do placements. So you're getting experience whilst you're learning at university. And then when you qualify, you join the HCPC register, and then you would apply to do a job in one of those settings that Janet talked about before. So yeah, a very diverse group of people working across the whole spectrum at all different ages. So it's a really brilliant career pathway. So I can't recommend it enough. So I'm a physiotherapist, you know, I've had a brilliant career and now working in this role. So it's lots of opportunities for you. Okay, next slide. So what we're going to cover today is we're going to focus on 3 of our AHP professions. So we've got some lovely dietitians, some ODPs, and some prosthetists and orthotists, and they're going to tell you all about their experiences and, you know, what they found, what they like about their role, and, you know, there's going to be an opportunity to ask a question at the end. Okay, so next slide. So I think we're going to start with our lovely dietitians. So we've got Laura Askins, Dove Yu, and Daniel Booth. So welcome.
Thank you. Lovely. Shall I take it from here?
Yes, please.
Yeah, okay. I'll have to remember my Chris Whitty next slide, please, because I'm not used to not clicking along. So morning, everybody. My name's Laura. I am one of the senior specialist dietitians here at South Tees. I'm here today with my wonderful colleagues, Dove and Dan, who will speak in a moment after I open up. But essentially, we're here today to try and encourage, persuade, pull everybody into wanting to work as a dietitian, because I think the 3 of us will agree that it's been a fantastic career for us. Some of us are further down it than others, but no day is the same, and you can get some really wonderful career fulfillment out of being a dietitian. I've been doing it now for about 15 years, and I started as a dietetic assistant up in Newcastle. I then went and retrained because I enjoyed the role so much and loved being within the team. And then over the last kind of 10 or 12 years, moved into various clinical roles, both within the NHS and private. I had a private clinic in Mayfair for a number of years, but then I also stepped out of dietetics to lecture for a bit, which was wonderful, and just goes to show that even if you want to move in and out of clinical, you can do. There's lots of opportunities for us. So essentially that's what we're going to go through this morning. Next slide, please. So what will we talk about? So I'm going to discuss about what a dietitian really is, because I think sometimes there's a bit of confusion in what we do day to day. We'll talk through who we work with, where can we work, which Janet's kind of already touched on, the settings that we work in. We'll talk through the progression prospects, because there are a lot of them, and certainly at the moment there's a huge demand for dietitians, so there will always be a role for people who would like one. Dov's going to talk through the type of activities that make up a typical day and talk about her background and how she got into dietetics, as will Dan as an apprentice. And we'll finish with what we love most about our roles, but hopefully that will come through in what we talk about by and large in our slides in general. Next slide. So what is a dietitian? Now, the next slide, if you don't mind going on to it, is a video which I'll encourage everybody to watch at your own leisure. We created it in our department. I'm not going to play it today because it's about 3.5 minutes. I'm conscious of time. But it's a really good video to demonstrate the kind of areas that you can work in. You can see our colleague Sarah there in the renal unit. It follows a number of dietitians within our department into various settings they go into, and explains really nicely about what we do day to day. But I can touch on it a little bit now. So if we go on to the next slide, essentially what we do as a dietitian is give specialist advice on food, health and nutrition to those who need it. Now, one of the questions I'm sure Dov and Sarah and Dan will all agree that we get is, well, what's the difference between a dietitian and a nutritionist? It's a really common question to get. By and large, a dietitian is a registrant with a HCPC, so that's a Healthcare Professional Council. So they are required to have clinical placements as part of their training, and there's an alignment with the British Dietetic Association within that. We're regulated by laws, and we have an ethical conduct that we have to adhere to, which means that as a registrant, you have to make sure that all of your practice is in alignment with the evidence base and the requirements to practice within that code of conduct. Nutritionists are a little bit different. So nutritionists tend to work in public health rather than the NHS or perhaps local government. They tend to work around more in healthy eating. And actually their title isn't protected by law, so actually anyone could call themselves a nutritionist, believe it or not. But many are working within the Association of Nutritionists Federation, but they're not generally able to work in clinical or hospital settings because they haven't gone through the clinical placements that we do. So that by and large is what a dietitian does. We do things like calculate requirements. If we go on to the next slide, please. Thank you. How do we do this? So, and the next one, forgot how many slides I've got today. So we do this by working out food and fluid intake. So we will calculate specific requirements to our patients, depending on what their needs are and what their clinical presentation is. We'll investigate nutritional needs. So if somebody presents in clinic, it's not always obvious about what they need. Sometimes they don't even know why they've been referred to the dietitian. So we use our really highly trained and astute communication skills to do this. So one thing to add in here is that as a dietitian, very rarely do you do any kind of prescribing. We do have prescribers now, but it's not that common. We don't suture, we don't operate, we don't do all of those things. We have to use our communication skills to get a rapport with a patient that helps them to understand why they perhaps need to change their behaviours, because often nutrition support is around behaviour change. We do this through creating care plans that the patient's been involved in. So we will talk with them, do assessments, explore their anthropometrics and biochemistry and their needs in that respect, and come together with a joint care plan that the patient's invested in and can align with going forward. We support patients who perhaps need extra feeding. So not all patients can eat and drink. We sometimes see people who maybe have been really unlucky and had a stroke, or have a neuro injury, or maybe going through some cancer treatments and need some temporary tube feeding. So we will calculate what they need and support the administration of that. And sometimes it might even need to be into the vein. So we will help with something called parenteral nutrition. So that's where we're giving people direct nutrition, bypassing the gut. We do a lot of work with in education. So in my initial role as a dietetic assistant, I actually worked with Newcastle United Football Club, and we did a huge rollout of education for children alongside Newcastle United, getting them more active. So that was a lot of fun for me, but it helped the children of Newcastle to kind of learn a bit more about food and nutrition, why it's so important. But we do that with adults and the elderly as well, and parents on weaning groups, things like that. But also dietitians are really heavily focused on the evidence base. So we look at the effect of nutrition on health and disease. So some of the cutting edge research coming through at the moment is very much looking at gut health, so microbiome health, so the gut and the brain and how that works together, but also about muscle wasting and how important maintaining good muscle mass through the ages helps prevent the onset of certain diseases. Next slide. So where do we do this and what areas do we work in? So there is a huge array of specialities, and generally you kind of specialise after you've had your first couple of years of working in healthcare, after you've completed your training. So we work in mental health, so that's a huge area of dietetics at the moment. In the acute sector, we look after people with oncology diagnoses, gastro complications, cystic fibrosis, diabetes, neuro, renal. That's a huge part of what we do as well. But there's some dietitians who specialise in other areas as well, including sports nutrition, freelance, or pregnancy and menopausal support. So the world's your oyster, essentially, is what we're saying. You can sometimes start small and end up really big, and you can do research as you're going along and develop your career as you would like, essentially. Next slide, please. So I'm going to hand you over here to my lovely colleague Dove, who's going to talk you through her dietetic journey and also what she does on a typical day-to-day to give you a flavour of what we do.
Hello everyone, so my name is Dove. I'm a senior specialist dietitian working in oncology and palliative care, both in the acute and community settings. Just wanting to share a bit about myself, so how I get to dietetics. So I did a food and human nutrition degree at Newcastle University, which includes a year of compulsory placement. So I spent there in the Medical Research Council, human nutrition research involving sort of some research around the National Diet and Nutrition Survey, looking about the population sort of diet intake. And then after I graduate, I went straight into dietetics, doing my postgraduate diploma at Leeds Beckett University. And you can see a little tiny picture there. It was me trying to experience a nasogastric tube insertion so that I can feel how my patients would feel like when they struggle, for example, swallowing or they have a stroke, to use like tube feeding as a nutrition support format. And after my 2 years of postgrad, in my placement, normally it consists of 3 placements. The first one is sort of 3 weeks, mostly sort of shadowing. The second one is sort of 12 to 13 weeks with the third one as well. So that would be really learning, develop those skills. And for my final placement, I spent it at South Tees, where I'm working with now. And then after I graduate, I got my first Band 5 rotational dietitian job at South Tees, and after a year, I progressed to a Band 6 specialist job, and yeah, I'm still working in South Tees now. And I'm also a committee member of the BDA, British Dietetic Association, Older People Specialist Group, and also the Oncology Specialist Group. Next slide, please. So about a day in the life of a dietitian. Typically, we work about sort of 8:30 to 4:30 in a day. In the morning, as a dietitian, obviously, we need to make sure that we're well nourished and hydrated. So get a cuppa, and then checking everyone else, because we need to look after ourselves and the mental health of others as well. And then normally we check any sort of emails and tasks and any sort of new referrals and try to triage both inpatient and sort of outpatient referral and plan the day. For example, today is my upper GI oncology day, so I'll look at any patients that are coming for radiotherapy, and I'll see them in clinic. Or if there is any patients on the ward, then I'll see them. So yeah, we'll go into the ward and see the patients, and then afterwards I'll do maybe some outpatient phone calls. Afterwards, sort of lunchtime, I normally quite love meal prepping because that's my passion as well. So next slide, please. Then typically in a day, normally we'll have several meetings crops up. For example, today it would be a presentation now. And then someday I might have like a meeting with upper GI nurses or dietitians, sort of discussing any issues around and trying to improve that, to make sure that we communicate as a team and using an MDT approach as well. And then I normally, as I mentioned earlier, I'll do like a radiotherapy clinic. So typically I will see them either in the chemo day unit or radiotherapy unit. Normally, because they come in, they will have sort of quite invasive treatment for about sort of 5 weeks for my patient group, and I'll see them weekly. And one of the things that before I actually become a dietitian, I didn't know that is actually this is what is really essential. Calculator. I didn't know that I need to calculate all the time with sort of requirements and how much their intake is, and sort of compare that and sort of determine how much they need. So, and then afterwards, I'll do quite a lot of administration work. For example, if the patients, I feel like they're actually not managing enough orally, then I will need to liaise with the consultant and also the upper GI nurses for any sort of admission for nasal vaginal tube feeding, etc., and also arranging sort of supplement prescription. And then afterwards will be home time, and I'm normally quite active, so I'll go to the gym or run and do any activities to stay active. Next slide, please. And now I'll pass over to Dan. Oh, sorry.
I think it's, yeah, thanks, Dove. That was brilliant. So in terms of how would you become a dietitian, next slide, please. There are several routes in, but generally you have to do a degree or apprenticeship in dietetics at a university, as we kind of alluded to earlier. This is where you'll learn most about food and nutrition and how it'll affect people's health alongside some clinical placements. Next slide, please. So by and large, to attain one of these courses, you need to have at least 5 GCSEs at grades 9 to 4, so A star to C, including English, Maths and the Science. You need to have 3 A levels, including biology, but some courses also ask for chemistry. I think most actually ask for both of them. There are other routes available, which Dan's going to go and speak about in a moment, but these are the key things to consider whether you're looking at an apprenticeship or a degree entry. Next slide. So I'll hand over to Dan at this point. He'll talk about his role as an assistant and how he got into the apprenticeship.
Hello, cheers, Laura. Yeah, so my name is Daniel. So currently I'm a dietetic assistant, also a dietetic apprentice. So I've just finished my first year of my apprenticeship course. It's a 3-year course. So the way I got into that was initially got a job as a dietetic assistant, and I've been doing that for about 7 years now. So it's a good way, especially if you're a bit older, as I am. It's a good way of kind of getting into dietetics without having to go back sort of full time to university. So the dietetic assistant role is similarly what you've heard from Laura and from Dove. We do a lot of that sort of stuff, but we see less complex patients, and we assist in the kind of more kind of basic things that the dietitians will do. So we do lots of stuff about calculating and monitoring people's intake and discussing nutritional plans with patients and things. And we'll also deliver nutritional support to patients. So I see patients on the ward all the time. I saw them in clinics and stuff when I worked in community. So I've had to go at various different things in the time that I've been an assistant. I've worked in community, in nursing homes, in oncology. I've worked in gastro. I've worked in pediatrics. I've kind of, had a bit of a crack at most things in my time. So like I said, we essentially sort of do a lot of stuff the dietitians do, but we kind of free them up, I suppose, to deal with the more complex patients. So anybody who needs, as Doug was saying, sort of NG feeding or feeding through the veins, parenteral nutrition, all that stuff is kind of much more complex and needs much more time. So we can sort of take a bit of that pressure off by doing some of that less complex work. That's still, so we get, and I got all that training as I started the job. I had no qualifications in any kind of nutrition before I got a job as a dietetic assistant. Not entirely sure how I managed it, but You know, I'm good at talking, I think, is the basic prevalence of that. I knew a lot about AHPs in general. My mum was an occupational therapist, my sister's an occupational therapist, and my wife is also a dietitian. So they did kind of tell me what to say to get through it. But yeah, so essentially now I'm on this apprenticeship. If you want to skip to the next slide. So yeah, the apprenticeship's been brilliant for me. Like after a couple of years of being a dietetic assistant, I realised that it's probably something I wanted to pursue to become a dietitian, but I couldn't really, you know, I was older at this time. I had a child, I had a mortgage. I couldn't really afford to quit my job and take out massive loans and go back to university. So they talked about apprenticeships for a long time. It never happened. And I just sort of kept waiting. And then eventually, a couple of years ago, they started doing dietetic apprenticeships. So I think the first one was in Coventry, and the second one now is run out of Teesside. Luckily enough for me, it's exactly where I live. I live very close to the university, so it was very convenient for me. Well, you can do that course from anywhere. They've got people on my course from like Bristol, Coventry, kind of all over really, because they can dial in and do it completely online if they need to. But I do a kind of mix of online and physically in sort of university as well. So that's been interesting. So I've done like a year of that. So the way that works is I stay in my job. I do 4 days a week in my normal job, and I do 1 day a week at university. And then we also have placements exactly like Dove had. We have an A, a B, and a C placement. Starting off sort of shadowing, then getting more hands-on as you go along. It's sort of slightly different in terms of like, because we've already got a lot of the skills that they teach the students, so we're kind of probably slightly further ahead than a lot of the students that we get who come traditionally through those university routes. If they haven't had any sort of clinical time before. So, but I think the biggest sort of difference has been because a lot of us have been out of education for a long time. I do have a previous degree, but it's in politics, and I did 20 years ago, and it's completely irrelevant. But so I hadn't done any science or any kind of that kind of stuff for 20 years since school, really. So since GCSE for biology and things like that. I know A levels in science things. I've got A levels in humanities subjects. So it's the fact you might need all those things to get onto undergrad courses. If you do, you know, if you're coming to this later in life, or if you do want to go and think about it later on, or maybe try and get a job as dietetic assistant and go that route, you know, you don't necessarily need those qualifications. So I think the only thing you definitely did need was to show that you had studied at a degree level before, which I had done, even though it wasn't a particularly relevant degree. You know, so it's been really rewarding this past year, and the whole sort of 7 years I've been doing this. I mean, it's not all been smooth sailing. For example, when I started this job, I did have hair, and these things happen. It's just getting older, and the stress in the NHS. But it's a really good job. It's a really rewarding job. And at the end of the 3 years, I will have my degree in dietetics. I can register with HCPC, and there'll be a job for me here. Hopefully, no, there will be a job for me. I'll walk into the band 5, which is really good as well. So I've got a guaranteed sort of employment, and plus it's good for the trust because they paid for me to do it, so I'm not paying anything. And so even though I don't have to, but I'm gonna stay here. You know, I'm a Middlesbrough lad, so I'm not going anywhere. The next slide. Thank you.
What a sales pitch, Dan. Cheers. Thank
Cheers.
you. Brilliant. So just to wrap this up, because I'm conscious of time, so financial support is available for those wanting to pursue a dietetic course. I think it's up to £5,000 is available, but if you're wanting to look into this, I would suggest looking at the BDA website, the British Dietetic Association, and they will be able to guide you in terms of which route from a financial perspective may well suit you more. Next slide. And in terms of now, well, which one are we doing? And the next one, go on, skip me along. So ultimately, this is a really good job. It's flexible. There's lots of opportunity. It's in demand, both in the UK and abroad. But certainly, I'd always encourage everybody to stay in the UK and work for our wonderful NHS. The pay is reasonable, and as we sort of already talked about, there is support available there from a finance perspective. If you want some next steps, which is the next slide, what we would suggest that you do is you start to look into opportunities to shadow and volunteer. So we have opportunities here at South Tees for anybody who's interested in doing this. Please just get in touch with the organisation, and we'll try and get you into some shadowing opportunities, which includes work experience. We have a careers event in October where you can come and see what dietitians do. We've got a table out. I think that then there's the Strive AHP days as well, which gives you the chance to kind of see what's going on with different careers, not just dietetics, but others too. There are often regular opportunities to get involved with care work or a nutrition charity. So again, look at that, because when you're filling out your applications, these are things that will put you a step ahead of others that may not have that experience. There's loads of resources on the BDA website. Look at dietetic assistant roles as well. As Dan said, you know, it's a great foot in the door. You learn a lot of the skills that you would need on a dietetic course anyway, and it gives you a lot more confidence once you become a dietitian if you do go into that route. I know I certainly probably felt like an underconfident person, or I would have if I hadn't have been a DA first. And then lastly, there's loads of social media pages on this now. Lots of dietitians have a platform. Dove has one. I don't, because I'm prehistoric, but there's other dietitians that do, and a lot of the researching dietitians as well put a lot of stuff out there. So there's loads of opportunities to get into this in a subtle way before you take that next step into the applications. And I think that's it. Is that us? Next slide. Yeah, just finally, there's your BDA Careers website for anybody who's interested. Thank you for your time. We really appreciate it, and we'd love to see you soon in some of our events coming up.
That's absolutely brilliant. Thank you so much. Okay, if we move on to the next slide. So that's everything from dietitians for now. So what we're going to do is move on to prosthetists and orthotists. So we've got Scott Murray and Hannah West who are going to talk to us all about that. So thank you so much to the dietitians there. Thank you.
Good afternoon, everybody. Don't you just hate it when you have to follow a really interesting presentation? I think I might apply for a role as a dietitian apprentice, if there's any going.
Yeah, me too.
So my name's Scott Murray. I'm the principal orthotist here at South Tees Hospital, and hiding somewhere in the sea of heads is my colleague Hannah, who is a prosthetist here. I qualified in 1998, and I've worked as an orthotist for the past, let me count that, 26 years. 23 years based at South Tees, and for the first 22 and a half of them, I was employed by contractor. So it was a private employer providing clinical service to the trust. From January this year, the trust actually took us into employment. So it'll hopefully make sense why I've mentioned that later on in the presentation. But Hannah, my colleague, is currently a contractor. She's been here for the past 10 years. But their service is also looking at how they can potentially bring that as an in-house service. So if we move on to the next slide, I think our job here is to try and spend the next 10 minutes or so getting you to hopefully understand what the mysterious world of prosthetics and orthotics actually is, because it's a very little known role. So for anybody that doesn't know, a prosthetist is someone who provides artificial limbs to somebody who's had an elective or a traumatic amputation, or was maybe born with a full limb or part of limb missing. When you become a prosthetic patient, you're pretty much going to be involved with that department for the whole of your life. So you form really close bonds and you develop really close links and relationships with that person. And the whole purpose of what we're trying to do is to provide a device which either provides function or a cosmetic replacement for that missing limb. Next slide. Prosthetics and orthotics are a bit like a brother and sister qualification. So whilst prosthetics services people with limbs that are missing, orthotics provides supports and devices for people who have limbs or body segments which don't function properly. So our role is to try and provide devices which will improve function, reduce pain, and reduce or accommodate deformities. And they include a wide variety of things, from the neck down to the feet, including insoles, footwear, foot and ankle splints, knee braces, chest braces, and spinal supports. Next slide. So we are by far the smallest of the AHPs. I think there's around 170,000 AHPs at the minute. So we're about 0.5% of that population. And of the 1,200 qualified clinicians, it's about 800 orthotists and about 400 prosthetists. It's a dual qualification, so when you finish your training, via whichever means you go through, you qualify to do both roles. Although currently there isn't an awful lot of opportunity to stay practicing both at the same time. So by the end of your training, you have to decide which role you prefer to kind of move into. I think the situation we're here in South Tees at the minute, with both departments potentially going to be in-house at some point in the near future, I think there's maybe an opportunity for us to explore the possibilities and the potential benefits of having people that work across both services. So I think that's a bit of an interesting thing for us in particular. Currently, there's 3 routes into becoming a prosthetist or orthotist. So there's the university degree. There's 2 places in Britain that do that at the moment. So you have Strathclyde in Glasgow or Salford near Manchester. There's a master's route for people that have a qualification which is of a similar type of thing to the degree that we do. You can do a 2-year conversion into the profession, and like the other AHPs, there's an apprenticeship route which is run by Derby University at the moment. So I'll hand you over to Hannah, who will talk you through a bit more about the role as a prosthetist.
Yeah, we'll just go on to the next slide, please. Thank you. So yeah, my name's Hannah. I work for a company called Autobock, and we provide the NHS service in James Cook Hospital in Middlesbrough. Within my role, I work with a lot of people, working with prosthetic technicians who actually do all the grunt work in our job. They actually physically build the leg. We work with physios, occupational therapists, and they are the people who help train our patients to work at home and to be able to live their lives more normally. And we take referrals from consultants, GPs, physios, everyone across the board. I work in an NHS clinic, but you're also able to work privately if you work as a prosthetist. And we generally work in an outpatients setting where we, as Scott said before, we work with patients throughout their lives. We will do anything from prenatal appointments all the way through to working with patients who are very elderly. Our eldest patient was 104 when we saw her, so it's a great role to work in. I work for a private contractor for the NHS, so it's a 4 to 5 year progression, working from a graduate prosthetist up to a senior level. Within the NHS, it's very similar. You tend to start as a band 5 and work your way up towards a band 6. Higher roles tend to be, higher banding tends to be for more management roles. You also, in very limited cases, have the option to specialise. So that tends to be specialising in things like upper limb prosthetics, but generally everyone's trained across the board to do everything. All our patients are so unique that you have to be able to turn your hand to pretty much anything within our patient group. And that is the thing I love most about my job, is I get to work with something very, very different every single day. We work with people from different walks of life within our service. We cover North Yorkshire, we cover up Hartlepool up to Durham. So we get patients from all walks of life. We see amputees with vascular compromise. We see farming accidents, we see road traffic accidents, we see all sorts of things. So everyone's very, very different. If we can just move on to the next slide, please. So a typical day in my job can involve just about anything. As I said before, we can start with MDT clinics where we are meeting new patients, and that's generally after an amputation or with young children if they've acquired if they've been born with some sort of limb difference. We spend a lot of time talking to people. Obviously, it can be quite a traumatic thing to happen, to have an amputation. So a lot of our job is just talking to people, giving advice, making sure they understand the limitations they may have and the options they've got for the future. we just as day-to-day activities, I can do things like casting patients for new sockets. So for me, that's taking a plaster of Paris cast of the residual limb. We can also scan for them, we can take measurements for them. There's all sorts of different ways of making a socket, and that will very much depend on the patient that's in front of you and what their needs are, what sort of shapes they are. I will then rectify that cast, so that means filling it with plaster of Paris and adjusting it to fit my patient exactly, and that's when I'll then work with my technicians to actually make the limb to my prescription. There's a massive range of feet and knees and bits in between out there, so that's, I have to be across the board on everything with my knowledge with that. That prosthesis would then be fitted a couple of weeks later. That's a very involved process for me. I have to be able to observe my patient's gait and fully understand how they walk, why they walk a particular way, how I can fix that, what training they need. That's where we might work with physiotherapists. We might do quite close work with physiotherapists on quite specific problems that patients have. And as Scott said before, we work with patients for life. It's really important to build up a good rapport with our patients, because they rely on us to be able to do their day-to-day life. If that's taking the kids to school, working as a nurse, just managing to make their own dinner, it's really important that our patients have a good relationship with us and can come to us and say, actually, this leg's not quite right, or this arm's not quite right, we need to adjust it. And we work with them. They come back time and time again, and we figure things out and perfect everything. And that's the best part of the job, is having that relationship where we can talk to people like that. And the other thing that we do, that I haven't mentioned, is we also speak to people prior to amputation. If somebody knows that having an amputation is going to be their only option, or one of the options they have to choose, then we will counsel them. We will speak to them about the different prostheses they might have, the time scale for rehabilitation, and generally support them, and then support them all the way through their rehabilitation. And that's it. I'll pass you back to Scott to discuss orthotics.
So I think, unsurprisingly, because we are a dual qualification and a lot of the kind of background training is very similar, the day-to-day roles aren't as dramatically different as you would think. So again, our referral pathways, we'll get a lot of referrals from consultants, GPs, and other AHPs as an adjunct to any therapy or patient management that's ongoing from different departments. As I mentioned before, you can work either through a private provider contracted into a clinical service, or directly employed by the NHS. There is also the option of going completely private and managing your own developing your own caseload of patients. But for most people, whether it's being employed by the NHS or being employed by a private company, most of your clinics will be either hospital-based or in primary care. Will quite often provide services within special needs schools, or for people that require it within patients' homes to hopefully get them back mobile and back into the community again. Day to day, most of our clinics tend to be in an outpatient setting, so you manage your own caseload of patients. We do get involved in a lot of multidisciplinary clinics as well, where you'll have different healthcare professionals involved in patients with complex needs care to try and make sure that we get the best outcome for them. So currently we're involved in paediatric MDTs. We've got good working relationships with the orthopaedic foot and ankle specialists. We're involved in the management of diabetic foot conditions and the prevention or the healing of ulcers, and using tools such as pressure measurement systems to try and offload areas of high pressure and prevent re-ulceration again. And most recently, we're involved in a newly established chest wall service, where we're providing specialist bracing for people who have conditions called pectus excavatum, which is a sunken chest, or pectus carinatum, which is a prominent chest, and trying to remodel that chest shape with the plan that we can hopefully help them to avoid any future surgery. Very occasionally, we might get called into theatre. So if we have a child who has developed a contracture and they've had to go in for a soft tissue release, they need some kind of support following that procedure, we'll be called into theatre and we'll actually take a mould of that person's leg post-operatively to make sure that we get the device provided as soon as possible. Next slide. And similar path to the prosthetics, obviously. So being employed by a private contractor, which the vast majority of clinicians or orthotists in England and Wales would be, it's a 45-year progression from graduate orthotist through to autonomous clinician. In the NHS, it's maybe more of a structured approach where you enter as a graduate at band 5 level, and then throughout your career, as you continue to gain experience and develop knowledge, you can look into moving through the bandings, looking at the kind of clinical specialist roles, getting involved in research projects, and getting involved or being supported to be involved in further education. My typical day, fairly similar to Hannah. I have our own caseload of patients, usually varies between 15 and 20 within a day. The caseload will be made up of new patients for assessment, fitting of goods that have been measured previously, and reviewing and monitoring patients' progress. For the patients that we assess, once we've agreed a goal and what we're trying to achieve, we'll then take measurements for the particular device that we think might suit them best. So that might be as simple as using a tape measure to take a circumference. It might be using a soft foam impression box to get a mould of that person's foot to make some insoles. We quite often take casts of arms or legs to make devices to control particular movements, or we'll use scanning equipment that we can then send through for CAD/CAM or 3D printing as part of the manufacturing process. Fitting and adjusting devices. Our role is quite a hands-on job, which is one of the reasons why I like it. It's not just kind of sit down thinking all day. It's a bit, probably the wrong age group for us, but a bit Blue Peter in terms of being kind of physically involved in stuff and adjusting stuff and making it fit and making it work for that person individually. So you use various types of equipment to make sure that these devices are fitting, comfortable and functioning as well as they can. And I'd say that the thing that I love most about my job is that every person is unique. Every situation is individual. You constantly get you thinking. You can see the same type of patient with a similar condition, but there might be 3 or 4 different options available that would best suit them to achieve the goals that they want to achieve. And I think like most of the other AHPs, the reason why we do this job is because we do genuinely involve helping people. And you get a lot of job satisfaction from that, which really does make it worthwhile. And I think that's our presentation.
Thank you so much. That was absolutely lovely to hear. So interesting and things, that can really, really help patients out there. So yeah, a really, again, interesting presentation. Thank you very much. So what we're going to move on to now is our operation department practitioners, or you might have heard them be called ODPs. So we've got Bruce coming up first, and then we've got Helen afterwards. So if I can just pass over to Bruce Hobson, please.
I'm just going to check that Bruce is on the call, and if Bruce isn't on the call, we have a wonderful ODP who's happy to step in, called Jen Trafford, who I've just appeared on the call. So unless Bruce jumps into the call, I've just sent in the link again, but there may have been some clinical pressures. If that's okay, Jen, I will hand over to you, and very, very much appreciate this because this is definitely off the cuff for Jen.
Doesn't look like Bruce has been able to join us, does it? Right. I will wing this as we go along. Thank you.
True AHP world, though. This is, isn't it? Where you adapt and flex.
Yeah. If this is one thing we're good at, is this. It's been shot in at the deep end and adapting. Yeah. So I'm Jennifer. I work for South Tees NHS Trust, and my background is Operate Department Practitioner, or ODP for short. My career started, I was later, I was a mature student, so I went through college and did access to health course at Redcar College, and that opened the doors for me to then be able to go into a healthcare university course. And I looked at, I'm going to be honest, originally I was looking at becoming either a paramedic or occupational therapist. And when I was asked kind of like why not a nurse, I said that the ward based kind of idea was never for me, and at the time I said if I was going to be a nurse, the only nurse I would think to be doing is a theatre nurse. That would be something. And that was when somebody said to me, what about an operating department practitioner? And I'd never heard the term. I didn't know that was a thing. I just thought everybody that worked in the theatres were nurses, and we're not. We have a distinct specialty, and we train, and everything that we do is geared towards being a professional within that theatre environment, and that really excited me. So that was the first time I'd heard about it. So we are known as the SAS of the NHS. We've dealt with somebody at some point. Every time you've been to an operating theatre, you've probably come to see an ODP and just assumed that we're a nurse, but we're not. We're very much dedicated to the theatre. And we learn 3 different areas of the theatre. We cover anaesthetics and recovery, we cover scrub, and we also rotate as well. So we cover the whole of the specialties. A lot of trusts, once you've qualified, a bit like the last guys, we often get asked to then decide which pathway we want to take, whether that's, so I chose anaesthetics and recovery, and some people might choose to then go down and become specialised in that scrub area, but we are trained to do all 3, and a lot of trusts do encourage their practitioners to stay relevant in all 3 areas, and utilise that kind of like the way that works. I'm going to wing Bruce's slides, so go on, next slide, please. See where he's done, and then I'll... So just like the other guys, we are registered with the HCPC, so we have that registration that we have to adhere to. However, our governing body is the College of Operating Department Practitioner, is our governing body, and they're the ones that kind of represent us out in the big wide world. So next slide. So like I say, we do 3 different areas when we're training, and the first area that we cover is anaesthetic. I'm being told I'm talking too loud. The first area that we cover is anaesthetics, and what this is we help support the anaesthetist. So when you come down to theatre and you're being intubated, we're the people that help make sure that you're safe within that area. So we're the people that generally come along and check you in before you come to theatre. So one of the really key things that we need to have as practitioners is the ability to instantly connect to people, because from the moment that I come and collect you and do that initial check-in, I've got to make sure that you are feeling safe and secure with me, because you're going to put yourself in my hands. So being able to identify kind of different people, make that instant connection, it's really important, because we don't get a lot of time between that walk from the from when we go and collect you from either the ward or the surgical day unit and bring you into theatre. That's the length of time that we have to make that connection with you. So it's really important that you have good communication skills as an operating department practitioner. So we bring you along to theatre, and we're the ones that will make sure that you're comfortable. We make sure that you've got the relevant monitoring on, so that we can keep an eye on all your vital signs as we're putting you to sleep, as we're giving you that anaesthesia, and putting you off to sleep, we make sure that we're checking on your heart rate, your blood pressure, your respiratory rates. We make sure that you're warm and that your temperature's right, because once we've anaesthetised you, you lose all ability to be able to do things like shiver. So if you're, it's little things like that. If you're cold and you're awake and alert, your body will naturally start to shiver to try and warm you up. Well, the theatre environment can be very cold because we try to keep the temperature cold enough that it doesn't create bacteria kind of like growth. So the theatre environment can be very cold, but because your muscles are relaxed and we've anaesthetised you, you can't naturally shiver. So it's really important that we do even little things like that. Make sure that we're keeping an eye on your temperature, because that can have knock-on effect for things like your skin integrity throughout the operation. So all of these things we've got to be thinking about, and we are your advocate in that area. We advocate for our patients. We make sure that they're comfortable, that they're positioned right, that everything's going well, and then we help when you're anaesthetised. We also, with the anaesthetist, we might put in things like invasive monitoring, so arterial lines and central lines, which we can use to monitor your blood pressure, but instead of having it on a cuff, we can monitor your blood pressure internally, so we're getting minute by minute representation of what your body's doing as you're going through that operation. Next slide. And then the other area that we work in is we work very closely alongside the surgeons as well. So our job within the surgical field is to help the surgeon, and we're scrubbed, so we have to make sure that we are able to do a proper full down scrub procedure, so that we are sterile and we have an aseptic non-touch technique, so everybody within that blue field that you can see there are in a sterile field, and we make sure that that sterility is kept throughout. We also make sure that we've accounted for all of our instrumentation before the surgery even begins. We make a count of all of our sutures, our swabs, anything that might potentially be left inside a patient before the surgery's even begun. We make sure that we've done a full count and that we know how much instrumentation we've got there, and then periodically throughout this operation we'll do counts throughout the operation to just make sure that we've kept an eye on everything that's going on. We make sure that the surgeon has instruments that they need as they need it, and it's really important that we know the process of the operation that the patient's going through, so we know which instruments are needed next to keep the flow of the operation going. But also, in case something goes wrong, we need to know what are the emergency bits of kit that we need to clamp off any bleeds and things like that. It's a very technical job. So the scrub element of it, especially because within the scrub area we use a lot of instruments such as diathermy machines, which are machines which basically can cut and cauterize at the same time. So as you can imagine, that electric current going through, we have to know what level of current we need for different levels of tissue. So it's a very technical job that we do. We need to make sure we understand things like we have suction, and again we got to know at what level we need that suction, because what we don't want to be doing is sucking up things that should be left inside a body cavity. So that's really important. And within this part of this area as well, if we weren't scrubbed and being stood next to the surgeon, our other role would be to be outside of that surgical field. So you can imagine the people in there, if they need extra swabs, if the patient's bleeding and they need to absorb some of that blood, they might need extra swabs. They can't just leave that sterile environment and go get them things. So we have circulators on the outside, and their job is to make sure that, again, they know at what point of the procedure they're at, what might be needed, and then their job is to hand into the sterile area the things that are needed, but in a sterile fashion, in an aseptic non-touch technique fashion, to make sure that we are not introducing introducing germs and into that sterile area, so that we're not ending up with surgical site infections later on once we've closed that patient up. Next slide, please. And then once you've operations all done and we bring you off the table, and we then bring you into the recovery area, and now a lot of people don't even realise they've been to recovery after a surgery. A lot of people do not remember this bit of their journey throughout an operation, but most of them, all of you at some point will have been awake while you were in surgery, through your surgical journey when you come into us. So during this time we monitor our patients every 5 minutes. We do a set of observations every 5 minutes in theatre. In the ward areas you will get them doing it every half an hour, sometimes 3 hour intervals. In theatre we do it every 5 minutes. We also monitor the surgical sites to make sure that there's no excess bleeding. Lots of our patients might have things like drains, chest tubes, things like that we need to make sure that we are opening them at the relevant time. So depending on the operation that you're recovering will depend on what we need to do for that patient and how long that patient will stay with us in recovery. And recovery can be as simple as 15 minutes. We've seen patients wake up from minor surgeries, 15 minutes, 20 minutes later, they're sat up chatting away to us, and we're sending them back to the ward saying they're doing great. But equally, if we're having some really big surgeries or traumatic surgeries, they can spend a lot of time with us in recovery, while we do things like make sure their blood pressure is fine there. We give medications for pain management, so we do give medications as an ODP. We do give things like morphine and fentanyl. We also give drugs which help with blood pressure, bringing patients' blood pressures up or bringing them down, depending on the needs of the patient. So we do give drugs within our role as an ODP in recovery, and then once the patient's recovered. Once the patient's recovered and we're happy that they are orientated and that there's no excess bleeding, and that their pain is being managed well and can be managed then by the ward, we then call the wards and we would send that patient back to their ward area. And that's where most patients think they wake up. Most patients at that point come around, go back to sleep, they wake up on a ward and they assume that they've come out the operating department and gone straight to a ward area. So which is why we kind of ended up being this secret service of the NHS, because not a lot of people, the drugs we give you make us a little bit forgettable, unfortunately. Next slide, please. So we do go into other areas as ODPs. We're not just kind of latched onto the theatre department. So here in South Tees, we are often called down to A&E resus. So this is when you've had, so for example, a road traffic accident comes in and they feel that they've got an airway problem. We will often get bleeped and asked to go down to help support the anaesthetist with an airway, with airway issues, and we will go down and spend time in A&E, stabilising that patient, making sure that their airway is open and patent, and we can manage to get them to the CT scan and bring them up to the operating room or take them to wherever it is that they need to be. So we spend time in accident and emergency. I'm going to assume Bruce has put more than just, so we'll go next slide and see what he's put.
There's quite a few, maybe 3 or 4 more.
Thanks. Yeah, we also work with our radiology colleagues who are also part of our allied health professional group. And that's because, as you can imagine, if we've got young children, people with learning disabilities that need to stay still while they're going through these scans, it's really important to get the right imaging, that these patients are really, really still. And it's not always achievable especially with like young children and the likes. So we often we often heavily sedate them to go through. And again, as part of our job as looking after people's airway, we will often spend time down there and making sure that we're managing them that airway of them patients, so that they can get the right imaging to get the right diagnosis for future in their progression as patients. Next slide. And the other one that we work in is we often work with some of our more mental health institutes, looking after patients with electric shock therapy. So Rosebery Park here in Middlesbrough, these do it, and what that is for people who suffer with really, really deep depression, and the idea is that you essentially, I was once told by one of the consultants, it's a similar situation to giving an electric shock to the heart, doing it to the brain. It's about resetting that kind of electrical impulses through the brain. But obviously, to do this, we want, again, them patients to be comfortable. So we help by making sure them patients have the right level of sedation to be able to have that electric shock treatment, so that it's effective but without being traumatizing to them. So we often spend time working with our mental health colleagues with the likes of this as well. Next slide, please. And we also work with maternity, so for both elective and emergency caesarean sections, and also for when patients have had children where they've tore as the babies come out, they'll often come to theatre to be sewn up when they've had a tear. We have, so it's at South Tees, we have 2 theatres down in our obstetric services. One's for an elective surgeries. So these are people that know they have to have a caesarean section for whatever reason that is. And them theatres run daily. And we're there from the start all the way through. So we check the patient in, we do spinals with these patients. So a lot of the time for the elective patients, we don't put our patients to sleep for these operations. They get a spinal anaesthesia, which is, or a lot of you will think of it as an epidural, but during this process, it's actually a spinal anaesthesia. And what that does is it makes sure that that mum-to-be is absolutely numbed from kind of like just below just below your rib cage all the way down, so that they can't feel what's going on, and they can we can get that baby out nice and safely, but the mum can stay awake so that she can see her baby as it's coming out, and still have that experience of being able to bond with the child as they are being born. It's a privilege to be in the operating theatre when these babies are being born. It's really it's a lovely experience. I'm not a sloppy person, but I have to say, the first time I seen it as a student, I shed a tear a little bit. It's lovely. But we also have an emergency theatre as well, and that's for them mums that obviously something's gone wrong. We have to get that baby out really fast for whatever reason. And that theatre, we tend to put the mums, they tend to be more anaesthetised, so the mums are asleep when this happens, and everything is very quick. Everything has to happen very fast. So the teamwork that we have to have when we work in obstetric theatres is really important. So being able to work as part of a team and see the bigger picture to understand, because it's really important that we get that baby out as quickly as possible. So it's really important as an ODP that we are able to see the MD, the multidisciplinary team working together, and see where every person's job fits in to get that baby out and to keep mum and baby as safe as possible. And then we also, at the end, we recover the mum, but there'll be a midwife, or the neonates team would recover the baby. We don't recover the baby as an ODP. That's a specialised, that would be a specialised team to look after that baby. Next slide, please.
Right, Jennifer, thank you so much for stepping in at the last minute there. That was really, really kind of you. You did a great job. So yeah, really interesting again, things that, you know, even I didn't know as an ODP, so that's absolutely fantastic. But if I can just hand over now to Helen. Helen's a third-year apprentice at the Northumbria Healthcare Trust. Thank you very much, Helen.
Hi, well, I think Jen's done a really good job of telling me what ODPs do and things, so I'll not really have to say much. So my name's Helen. I'm a third-year apprentice ODP in my final year. I've got 20 weeks left to go and counting. I'll tell you a little bit about my journey first. So I left school at the old age of 16 and pursued a career in veterinary nursing where I qualified. Later decided to transfer my knowledge and skills into healthcare, where I gained levels 2 and 3, which has assisted me in my position as a healthcare assistant in the operating theatre. I worked there for 8 years as a healthcare and then successfully secured an apprenticeship as for a 3-year degree level ODP apprenticeship. Absolutely have enjoyed the journey. Academic wise, I think has probably been the hardest part for me because I'm a mature student, so getting back back into those books and things has been a little bit it's been a little bit challenging, but we're getting there. I'll just briefly touch on what ODPs do. So we're allied health professionals and play a vital part of the operating theatre team, providing care and support to patients through all stages of their surgical journey. We work in 3 key areas, which is anaesthetic, surgery and recovery. As a student ODP, you also are placed in those 3 areas, and the amount of knowledge and skills that you gain over the 3 years during placement is just, it's very vast. A lot to take in, but really, really interesting. What the best bits about my training so far? So I've gained both academic knowledge and practical skills in all areas of the ODP expertise, as well as gaining experience working collaboratively with a team of highly skilled medical professionals who deliver high standards in quality of care to all patients. So the job's really rewarding. It's nice to see that what you do is a really good outcome most of the time. So what I'd say to somebody considering this apprenticeship, the beauty of doing an apprenticeship is this route. Not only do you get your fees paid by the trust, but you get your wage, which is like, everybody needs their wage nowadays. So and especially if you've got like family and bills to pay, not having the stress of worrying about where your money's coming from is really helpful. But on completion of this degree, I have secured a job already. I mean, it was secure from the beginning, so I'll become a band 5 registered allied health professional, hopefully in the position of anaesthetics, because I love that role. And I'll not have any student loan at the end of it, which is just, well, I'm just so grateful for, really. Is there career progression within the qualifications? The answer is absolutely. There are so many avenues, such as becoming a senior ODP, so that's like a band 6, anaesthetic associate, so you're more in the anaesthetic role, but you're under supervision, but you're actually taking charge of that anaesthesia. The surgical first assistants, so those are members of the team who are assisting the surgeons during surgical interventions. So they do more than what the scrub nurse does. So they're retracting instruments, holding cameras for laparoscopic work. They do a bit of suturing and things like that. And there's also education. So there's quite a few different roles that you can go into, but allied health, I think, is just evolving all the time. There's just new avenues for us. So yeah, it's a really, really good role. And I think the apprentice route has definitely been the right route for me. I don't think I could have done it any other way. So yeah, definitely a good route to go.
Lovely, thanks, Helen. Helen, there is just a question that just came up in the chat box there, and it was asking about is there an upper age limit with ODP apprentices?
Not that I'm aware of.
No.
One of the girls that I'm working with is in her mid-50s, and she's doing her apprenticeship, so I don't think so.
No. So in our trust, the entry criteria would be 120 UCAS points and some healthcare experience in a theatres environment.
Yeah.
So certainly no upper age limit, but they are sort of quite hard to come by. It's very competitive, the apprenticeship route, as you can tell, having your fees paid, having a paid salary, it's a very lucrative, it's a really great opportunity, isn't it, for people? So, the more common route is the sort of going off to university route, but it is a route that's there. But yeah, thank you.
Thank you very much, Helen, and all the speakers. That was absolutely fascinating. I've learned so much today. So that is takes us really much to the end of the webinar in terms of all the presentations. But there's a lot of resources out there for you to find out a little bit more about what it means to be any one of the 4 professions that we've focused on today, or any of the other allied health professions. In fact, if there's a QR code there to a site called Aspiring Allies, and that gives you a host of other information, as well as examples of different roles and the different types of jobs that are doing, a bit like you've heard today, really. There is also a quiz on there. So there's a QR code there for the quiz. And if you go on that quiz, you can sort of go through it and it'll give you an idea of what sort of allied health profession might suit you. It's a little bit tongue-in-cheek, has to be said. I think everybody I know who's done it so far has come out as an art therapist. But it's good fun. So well worth visiting. The other thing just to say as well is that in next slide then please, Paul, is that there is an opportunity coming up very soon for a bit of like virtual work experience. So there's this QR code there, and we can get this sent round to you, where you can register for some virtual work experience for the different professions. As I say, that this will be sent round to you, so you'll have access to it. Paul will make sure that that happens. So that'll give you hopefully a lot more insight into all the different professions. And other than that, I think they we'll be following it up with other information, including there is something called the WOW show that I shall put in the link here. So there's a link in the chat now of something called the WOW show, and that has collated together a whole load of different resources for well, a whole range of healthcare professions, including the allied health professions. So so lots of places where you can find out more information. But I'm really aware of the time. It's already now 2:20. So it's so next slide. Thanks, Paul. Anticipated us. Is there any questions? You still got all your experts on the line. If you've got any questions of any of them.
Janet, there's a question in the chat box. How do the roles of the nurses or ODPs overlap and differ? And then there's another one from the same person saying Jennifer said she was thinking of being a paramedic, but instead became an ODP. What is the attraction of one over the other?
Very good question. Jen, are you still on the line?
Ooh, good questions. So the role of the nurse and the ODP, actually, once everybody's fully trained, there isn't within the theatre environment, there is not a massive amount of difference between us. The biggest difference is that as an ODP, we train specifically for the theatre, where a nurse will do their general nursing kind of like throughout their 3-year and go to different areas. When they come to theatres, they usually have to do extra module to learn about anaesthetics or scrub, and they won't be able to cover both anaesthetics and scrub the way that an ODP can. They will generally specialise, but they will have to do an extra module to be able to do whatever it is that they're doing. But once they've done that module, actually, there's not we're a very, very integrated team in the theatre area, and you often won't see much of a difference between us. Why did I pick the theatre over paramedic. When I and this is just totally personal choice, so this is nothing against paramedics whatsoever. I found that when I spoke to a lot of paramedics, I think when you first think about being a paramedic, you think about them paramedic TV shows, don't you? Where they're all going around and saving lives and CPR, and a lot of the paramedics I spoke to said they spend most of their time talking people down off ledges, and it's a lot more about people's mental health, and they do a lot of more social care aspect, and again, that's not something that I personally kind of wanted to go into and down that path. I'm a much more technical, hands-on kind of person, so the theatre then kind of was the thing that attracted me, because then I got my ability to work with patients and make a difference to people, a bit like Helen said, kind of seeing good outcomes predominantly, but equally I get to do that technical aspect of things like using amazing bits of kit like cell savers, where we suction people's blood, put it through a centrifuge as the operation's going on, and re-give them their own blood back. Like, how amazing is that? You know what I mean? That you can be in an environment where you can do technical aspects of things like that, and that was why I become ODP.
Thank you, Jen. Any more questions? So, question just come in. 120 UCAS points was mentioned for access onto a degree apprenticeship. Will you have to look externally more for candidates in the future? There must only be so many care assistants with 120 UCAS points employed by trusts, and you may run out of internal candidates. I think that is a very good question, and I think you're probably fairly spot on there, actually. So we do know that at the moment our apprenticeships are primarily coming, or completely actually, for our allied health professions, are coming from our current sort of support workforce. But we do know there is now moves, say, within the nursing professions, where they are directly recruiting into apprenticeships, and that is because of the sheer pressure on the for the need of the jobs, and the numbers of support workers or healthcare assistants that are there in the workforce. So I think you're absolutely right. I think we will see that shift in the future. Not quite there yet for allied health professions, but I think it'd be watch this space in the future. Yeah, so internal could earn access to healthcare qualification, yes. And just in terms of career routes for ODPs, just for you might be interested in this, Jen, and Helen, but I've got a colleague who has just been made director of surgery and anaesthetics in a major NHS trust. So there you go, career opportunities all the way up to directors. So question there, Andrew, will it be down south first? Will it be down south first in terms of the apprenticeship becoming for external candidates? Maybe because of but who knows? I think we're probably across the country, probably in all a relatively similar position, to be honest. So there's still a time for another question if anyone's got one. But certainly thank you very much for all coming and attending the webinar, and because it's an hour and a half, it's quite a long time, isn't it? But hopefully you found it as fascinating as I have.